Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the cardiac catheterization at Mount Sinai Hospital in New York City. My name is Pedro Moreno. I'm a professor of medicine and an interventional cardiologist. I will be your moderator today. We would love to hear from you. So please send us your questions. You can use YouTube or you can use your website. And remember that all our cases, including the previous ones, are ready to be reviewed in ccclifecases.org. We have a great case today, and let me welcome Dr. Kinney, Dr. Kera, and Dr. Sharma, the leaders of our structural team, to present the case.
And Dr. Tang.
Yes.
Good morning to all, so the whole team. And of course, we have Anup Koshi, our fellow, and we actually have the future fellow, Dr. Tona. So, and the rest of the staff will introduce. Let's start with our presentation for this interesting case. Our cardiac anesthesiologist is Cesar Rodriguez Diaz, and rest shown here with Laracus on the echo, which is very important. So what we are going to show today is the 26mm Evolut-FX valve in a very small patient with a BSA of 1.5. So real petite. This is the key, our episode number 53. Patient presented with the increasing angina exercise intolerance, and as I said, body weight 63 kilo, height 149, BSA 1.57, and rest of the factors shown here. And patient did go under the echo, which showed severe aortic stenosis. You can see very high with a velocity more than 5.2, and was kind of trivial to 1 plus AR. So with that note, maybe we should show the echo, live echo, which is a calcific restricted aortic valve. As you can see, high gradient and normal ejection fraction. So this is the live echo stem.
Yes.
Teach us what's going on there.
Yes, good morning. Thank you, Dr. Sharma. As you can see, very hyperdynamic left ventricle. The aortic valve is thick and calcified, reduced mobility of the leaflets. I will show you the function, normal RV function, hypercontractile, normal RV function, some mitral annular calcification, two-chamber view, again, three-chamber, again, to see the normal function. This is a zoom-in view of the aortic valve, thick and calcified, decreased mobility, mild to moderate aortic regurgitation, as you will see later. You can see the aortic regurgitation here.
It was there only very minimal AR before, about a few weeks ago when echo was done here. Now it looks like a little more.
Yes, today is
AR
a bit
now.
mild to moderate.
Okay.
And velocity 4.85, we've got a little bit less than 5.2 from the previous echo. Maximum gradient 94, mean gradient 54. The annulus by echo is like 1.9 to 2 centimeters. As you can see, aortic valve area 0.7 centimeters square. Normal stroke volume index, about 55. As you can see here, the velocity is 646 milliseconds for the AI, which is consistent with mild, but by the Doppler color looks mild to moderate. This is the subcostal imaging, no pericardial effusion, normal function again, as you can see, thickened, calcified, severely stenotic aortic valve in the middle. Thank you very much.
Okay.
Stam,
So I mean, this is just
no intracavitary gradient, Stam?
No intercavitary, as you can see, no.
no intercavitary gradient. And just to say, it is not uncommon when you have a patient, outpatient, you do a testings and gradients are higher and things changes when they are under fasting, sedation, and so that's why probably some difference which we saw today. Okay, let's continue our slide presentation on this case. This is now the CTA. All right, let's read the CTA. Actually, it should be a previous slide. There's one more slide back. Can I do this? No. Okay, 1 second. We'll go. This is echo. I should be able to advance it myself. Yeah, good. Okay. Gilbert, you want to comment on this?
Yeah, so you can see the annulus is definitely a small annulus, area 378, perimeter almost 70 millimeters, but LVOT is even smaller, 311 and 63.2. Definitely a small annulus patient, kind of smart trial type of patient. Next slide. You can see the STJ is around 23, but the sinuses are small. You can see the non-sinus only around 24, and it's the left as well. And the sinus on the right is around 26. Very bulky non-coronary cuts. You can see the next slide. You can see if you put a 23 Sapien 3 valve, you could have run into problem because of the small sinuses, despite the left main being pretty favorable, left main height of 14, but the right corner is lower, it's only 11. So I think that's the reason why we think a self-expanding valve will be safer in this patient. The patient is rather frail, actually, despite her age, and also low BMI. Next slide. And you can see that the hockey puck will very, very calcified valve, explaining why the patient has such a high gradient. Next slide. And you can see the arch anatomy should be feasible for cerebral embolic protection.
Okay.
And Sahil can comment on the access and others.
Sahil?
Yeah, straightforward SS. No issues here.
Large vessels, a little bit of calcium, not much. So the whole question basically was, in this patient has a heart team discussion. And clearly, the patient 67, question is, do you want to do a surgical valve versus TAVR? So that basically was the issue. So there was a discussion, and because of, I think, what really drove us to make for the TAVR versus surgery, because the patient's underweight, lower BS. Frailty, that so clearly we actually recommended that maybe this patient, otherwise active, no coronary artery disease, we did a CAD, non-obstructive CAD, that this patient should go for surgery, but after all the discussion was that get a 26mm Evolut-FX with the femoral artery access and Sentinel cerebral protection device. Now let's update what we have done so far.
We have the Sentinel up there, and we can show the
show the Sentinel up there.
Yes.
So key is, and this is a very valid question on this patient. At age of 67, she get the TAVR. What will happen at age of 77? So that will be the part of discussion today. Explant TAVR or redo TAVR, and so we'll have a lot of discussion on that. Yep.
So another thing we can discuss is the coronary height and the calcification.
Right.
You can see the left coronary is still pretty reasonably placed, but the right coronary is a little bit of a concern. And also the amount of calcification, which can actually make the balloon expandable valve pretty risky here. It's not very easy. Even with an undersized balloon expandable valve, you are risking rupture.
Okay. Perfect. Okay. So we are with that note, we are ready to cross, and we'll go through the regular wires and so. And we'll come back to it. So one of the big issue had been, maybe all three of you can comment on our use of Lenderquist wire. Because there are more and more data coming that particularly with the self-expanding valve, the Lenderquist gives you the better outcome, lower pacemaker rate, but we don't use Lenderquist that often.
No, Dr. Sharma, that's with the Pro Plus system. I think with the FX, we have a paper coming out in JACC Activation, the first multi-center limited market release. Lenders only use about 1/3 of the time.
Okay.
And so we do it maybe with 34 valve, with horizontal aorta, maybe valve in valve sometimes. But yeah, no, I don't think Lenderquist is no longer necessary. In fact, Japan just launched Evolut-FX, and they've done over 1,000 cases, and they don't use Lenderquist at all.
Okay. And we also use Lenderquist for 10% of cases or less?
No, even less.
Even less.
Yeah.
And particularly the 34 one.
Yeah.
And horizontal. Okay. So Anu, keep saying what you did. Yeah.
No, we just used AR2, and let us go fluoro. Save. Let us show that again. Yeah. It's a tight. Go back to the. This is the way, right? Yep. Opening is
very restricted opening.
Yes. You see? So go to the same view. Yeah. And I think AR2 we were able to get the.
Is the origin of the RCA anomalous or
slightly anterior?
No,
it looked a little anterior.
Slightly anterior, yeah. But not really from the left cusp. No.
There's a big
see, you can see
calcium,
the calcium, but the opening was below that on the aerogram. So if you see here, keep rotating the AR catheter. Good, right there.
Nice.
See? Okay.
Good. So what is the next step now? This is the AR2 going inside the ventricle.
We'll change it to a regular J wire and then pigtail.
Okay.
We never cut short this step.
Yeah, because I can tell you, since we used this technique, we did not have LV perforation.
5 years.
Yeah, 5 years plus,
Plus.
that we had no LV perforation. We did used to have when we are not doing this routinely.
Yeah.
We had particularly very stiff ventricles. Actually, we had few perforations.
Yeah, the
And
pre-shape wire really makes a difference when
Yeah.
we use the Safari.
Yeah.
Even if you have to pre-shape yourself with the implants, that was some of the issues. Because the stiff portion, when you become an elbow, that becomes a spear.
Yeah.
So we've been really methodical in training our fellows. They do a lot of hands-on in our program, and they've had very good success.
Is this generalized for the rest of the world, it says, like in India?
Yeah,
they
India
use-
also the same steps. Yeah, so two steps: pigtail, change it to the first, and then change to the Safari, Lenderquist, or whichever wire you are
You're doing
using.
the BAV, right? What is this?
And so,
Wire.
so usually there is one more fellow. What happened today?
No, no, no,
I
no,
see.
no.
Okay.
So what's the preferred wire choice, Dr. Sharma, in India? In the
It's the same,
stiff wire?
Safari.
Safari, right? Yeah.
Very
Most
few
coun-
people use Lenderquist. Very
Yeah.
few people.
Also, a lot of people in Asia are smaller. So
smaller,
smaller LV, hypertrophic LV. I think Safari extra small.
I saw
That's our
Manish
preferred
come.
wire. This is what you see here in the screen.
Yeah.
So,
So we're doing a BAV here.
What is the valve of the balloon selection of the BAV? What is the size?
So this is a 20 BAV balloon.
Because
And the
why
reason-
not 18 or why not 22?
Yes, so this is a very calcified valve.
And annulus was just
Unless
about
it's
to.
borderline. LVOT is 19 actually. So you want to be careful.
No, but you want to not go beyond the minimum diameter, right, annulus?
Usually the average.
yeah. This one, you want to make sure that you open up the calcium for the FX to expand. I think that's probably the biggest challenge with this particular anatomy. In terms of being able to make sure the valve is fully expanded.
Okay, ready?
You want to avoid post dilatation.
150.
Oh yes,
Who's
absolutely.
moving? Okay, go. 150.
You can see how calcified it is.
Go. Stop pacing. You still
You can see this is a 20 balloon, and you can see it
Is there
doesn't
a
even
dent?
fully
Do
expand.
we
So-
want to do it
No, I
again?
think we're good.
No.
We're good.
No, it's okay.
AI, created AI already.
Yeah.
Yeah, so the question is that the balloon size for the
Careful,
tower,
careful.
pre-tower BAV, usually we go to the just around the smallest. We don't go beyond it because of the same region. And many people we know want to avoid putting a pre-BAV, pre-valve, but at the same time, direct valve, particularly with the self-expanding, always you end up in putting a post dilatation. So we want to avoid it. With the balloon expandable, I think many of the cases you can avoid doing a pre,
For most cases, yeah.
most cases.
Okay, come.
Unless it's a bicuspid or heavily calcified valve.
Okay.
So we do flush port at 3 o'clock. We look at make sure we don't hit the, interact the Sentinel. So we go in LAO projection. You can see here. Good. Good. Yeah. Here. Good. Good.
Make sure no
Excellent.
interaction with the
Pigtail.
Sentinel.
Yeah.
Go down.
So we're going to cross the valve now. Dr. Kara just crossed the valve. And I'm going to go to the cus overlap view in the meantime while he positioned the pigtail. So we do things simultaneously, and you can see that here. We're going to magnify in so that everyone can see properly. I think you're above the...
So what depth would you want here?
So that's a great question. So this one, you can see the sinuses are small. So I would not implant high unless you have to. No, in fact, we're going to implant
Go,
probably around
yeah.
5 and 6. The
Pigtail has to
pigtails
go
at the
down a
bottom,
little
yeah.
bit, or maybe the calcium is
Yeah, so
preventing it.
you want to avoid the coronary issue here. That's the key. And the STJ is around only 23. So,
I think let's keep it there. It's
Yeah,
very small.
not allowing.
okay. 150, please. Okay, a little lower.
Still high?
No,
we are
no.
good, we're
It's low,
good,
it's
we're good.
low, yeah,
Yeah,
it's good,
yeah.
it's
One more cine, please.
Pigtail is not going
One
down.
more cine, please. Oh, go deeper.
It's good.
Go deeper.
Go deeper, go deeper.
You're good. You're good.
Okay.
Go deeper.
Yeah.
Good.
Good.
Good,
Okay.
good.
Okay, 100, please.
So here we do want a depth of 5
Just
to
take your
6
time.
millimeters.
Here, this is very important to take your time and see how it looks. Okay, good. 80? So, okay.
And you're happy with the depth, huh?
Then we'll
Let's
see
see
it now.
We'll take it now.
Looks good? No?
Yeah,
Looks very good actually.
I think it's actually very
there's
good.
a dye sequestration,
Yeah.
and you can see that.
So we want to
That's
make
a
sure
nice
the right
step.
coronary is still open. You see, that's very important. We're not worried about the left main here, right?
Yeah, right is
Okay.
still good.
I think this is good.
Okay, so let me center the wire. Go.
Everyone agree?
Yes. Slow.
Okay. 150. Move forward.
Yeah, I have. It's a small little view.
Wire back, please.
Yes, I did. Center the wire. Slow release.
Give it time.
Yeah. Push forward.
Give it time.
Push forward.
Okay.
Push forward.
Enough.
Okay, good.
Yes.
Okay, 120. Okay, good. Okay, so now,
Okay,
The
good.
small annuli, you have to be really careful.
yeah, so we typically control pace to bring the catheter back to avoid any kind of interruption. Push forward. Yeah. Excellent. Very good. Okay, 100. Back up. Patient's rhythm is excellent.
Yeah, so Pedro, you asked, or actually Gilbert earlier, India versus here. So what they do is, before releasing the valve, when you open 80% plus, they wait actually 3 to 5 minutes
Yeah.
for self-expanding to adhere before they release it. We don't do it. That practice is not here, but
Excellent,
they do
very
it there.
nice.
Beautiful done.
Yeah, just otherwise it's the same
Do you
technique.
need to post or come
same
out?
way. No, we may have to do it post.
We might have, we might,
do-
let's
let's
see,
do-
but we have to be very careful. Okay, let's do echo,
Echo, yeah.
and let's
Come out.
walk the system out. Hold the sheath a second.
Walk it out.
Let me
Okay.
take
All
a
right.
look.
Yeah,
Ready?
I guess that technique may reduce the risk of embolization.
That's right. Yeah. Yeah.
Very good.
And now question will come, if you post dilate, what you are going to be? You are not going to dilate with the 20 post BAV, you have to go to a bigger one. 20, we go to 23, so mean was what 21.5, so we go 22 true, right? If we
No.
need to be 22 true or no?
I think
I
21.
think it's
21. 22
21.
might be too aggressive.
Okay.
here.
Yeah.
All right, let's see the echo.
And let's see, the rationale for the post dilation is the
PVL.
or the structural look or the
And PVL,
yeah.
just PVL.
Yeah. There's no much PVL on this
Yeah.
view.
Wow.
It's just central PVL from
Yeah, that's the wire.
Yeah, from the catheter. Yeah. Let's go short X.
So a very good point here. If you don't have a lot of leak and you don't have gradients, one of the other reasons to consider posting is for symmetric valve expansion, especially in balloon expandable
Exactly.
valves. This is a young patient, 60-year-old.
This
You have to
is-
think
no,
about
let's
durability
go-
of these valves as well.
let's go,
If it's underexpanded, you might have more
Capital.
pinwheeling and more valve
I think
degeneration.
there is some.
Yeah.
So that's another thing to
Go
think
back to
about
short axis.
from a-
Yeah, we'll take a look.
And comment on mismatch here.
Well, there shouldn't be mismatch. We're using a supraannular self-expanding valve here with Evolut, so and she's tiny. So what we're looking for, as Sahil mentioned, is the
Some
durability.
PVL,
You know,
yeah, see.
frame expansion and risk of halt. Now, obviously, you want to trade off
Yeah, so
against
that's-
any risk of potential harm to the patient in terms of annular injury
jumper,
because
good
the
Yeah,
leaflets are extremely calcified. So we usually take a look at the cusp overlap view as well to look at the frame and geometry to see. It looks on the regular
much here, no
coplanar
much.
view well expanded, but we always like to look at
Let's go
another
again.
view. Just to
Short
I
axis for
show the
bikini.
short axis.
Short X, yeah.
Yes.
And what about the gradient stem?
Yeah, we can do the gradient
see for
with the
AI now.
pigtail.
Clean the pigtail, we are going to go back in.
Yes, we can
Yeah,
do
I
a
think it's a
gradient.
good idea. These valves have a little more residual gradient compared to the balloon expandable.
No, other way around.
Other
Other way
way
around.
Other way around.
Yeah, yeah.
I
And
don't
this
see-
patient,
I don't see
because
much.
of the small height and BSA, we might have some gradient, but,
Hold on, stay
but
there.
overall traditionally it has been with a self-expanding mean gradient about 3 to 5,
Very
with
circular.
balloon expandable 5 to 8.
it looks pretty circular on echo.
Circular.
Yeah. I don't see much AI.
Okay, yeah,
it's
let's
all,
see.
valvular.
Yeah. Now, can
Okay.
you do a gradient for us also?
No PVL, yeah. We measure gradient. Let's go up. Yeah.
Well, we'll do the hemodynamic
So
gradient.
what is your
and echo
gradient?
Yeah,
No, they're trying now.
I'm getting
They're
now.
trying.
Doctor.
No, but the echo gradient, I can tell you what will be the cath gradient before even measuring. I always have predicted and always have been correct
Okay.
to the dot. No,
Let's
let's
see.
see the echo gradient first.
Peak gradient 23.
Okay,
That's a
peak
lot.
gradient is
Little
23.
higher.
So we probably will
Very
find
high.
about 8
Yeah.
No,
in
that's
single
a lot.
digits.
Should we post?
Should
But
be
now
about-
if the gradient
should be
is that
3,
high, both
then we need to post.
the Sahil and Gilbert, is
Yeah.
it because the valve is not fully expanded? Why they should be the gradient if there is not a much PVL?
Yeah, you can see that here.
Okay,
Yeah.
flush
On
both of
this
them
view-
nicely, guys.
You could suppose, yeah.
Flush and read.
And leave little blood in the LV
no,
one
that's-
so that do
no,
not.
So
we
you can
have
see
to
the
post.
valve is a little underexpanded
gradients, right?
because
Yeah,
of the
we have to
calcium.
post.
So we have to gently
Get a
pulse because
21
remember
balloon, true.
there's a
21. Yeah, take that.
there's a risk of injury, right, to the annulus as well, and the sinuses. So it's a balance. But I agree that we should try to post a little
Zero
bit
everything?
here.
0.
Good. Done.
It's very nice. It's very nice.
Yeah.
So here are the numbers,
Oh, what's it called?
Dr. Sharma.
There is actually nothing. By us,
Frame.
Yeah, I got
it looks
maybe
like 5, right?
yeah.
133 to 138.
No, we have like
5.
0 gradient
No,
here.
we have it on the top. See that 134, 140. So
No,
about 5 to
5,
6.
5
We
to
knew
6.
single digit, but question is, do we need to squeeze? What do you
And we
think?
I would
zero
do a
both?
gentle post
Huh?
No, we did. We reached
Yeah, we
zero
reached zero.
both.
We're done. Go.
Okay.
Okay, go with the 21 balloon. We agreed on the 21 true balloon. We are going to dilate. It's
Yeah.
reasonable because this case, you want to come out with the best hemodynamics for the long term because it's a relatively young age, 67. And I'll talk about
What
this
about
whole. Yeah.
What about post-ectopic gradient? No,
Well,
it's a little bit too late now.
yeah. Yeah, post-ectopic gradient assessment was more for deciding with the low flow, low gradient people that once you have post-ectopic, may substitute like a DSE. But yeah, there is a recent paper on that post-ectopic gradient, basically signifying it's a significant gradient not. If your node does not increase, that means there's the
Yeah.
myocardium run out. But I don't know whether post-procedure ectopic gradient, any data on that. But there was a recent paper in
20,
JACC.
21 true.
Yeah. You don't go all the way because the left side is
No, but
remember, it's very
21 no.
small.
This has to go 21.
the
Because remember, you have to go all the way because this is a 6-layer balloon.
Right.
Does not expand unless you go full, and there's no syringe needed here.
Right.
Back in a little.
Okay. 180.
Keep holding the wire. And always hold the wire. Okay, that keeps the balloon in place.
Okay.
Okay, going up.
Slow.
Okay, see that did not expand at the
It's
bottom.
still nice. Good.
Yeah,
that's
it's
fine.
okay.
Yeah,
That's all you need.
that's okay.
Continue, continue.
It does expand a little bit.
Let me take it out.
And we'll ask only
Okay,
the
pigtail
echo
again.
key now.
Off, pacer.
Off.
Let's get a pigtail again. You want to do another?
No, not because there was only 5, 6
Okay,
there.
then
but
let's
echo.
remove the wire.
Yeah,
then.
as long as they do. Yeah,
Echo.
take the echo wire out now. Take the wire out.
Apical
Yeah, good.
views. Apical
Okay,
views.
guys. Show us the echo now.
Come.
Apical views to measure
Show
gradient.
the echo on the main screen.
Yes.
The question was there infold before? You see that?
Not
And now
really.
you have to flow.
No,
agree.
it's just under expanded.
This
It's
chunk of calcium is under
Yeah.
expanded.
Did not expand.
yeah, you can see here.
Yeah, we didn't see.
Well, we started with a limited annulus, huh?
Yeah. No, but let's see now the gradient. So to us, it looked quite well before. There was no AI. Only thing was some residual gradient that have you obliterated the residual gradient on echo.
Definitely decreased
Much
gradient.
better.
Yeah. So became now 8.
Yes, yes. Get down, Dr. Sharma. Yes.
12?
Even lower, actually.
Yeah. So basically, which we have seen and the papers have been
4 and 7. Peak
Oh,
7.
yeah, 7.
Much better.
That's what we are talking about.
Fantastic.
Maximum gradient. And
This
this
is-
usually means the angiographic gradient will, hemodynamic gradient will be 0.
No, this is exactly what we see with supraannular
Yes.
valves.
No AI, nothing.
Yeah.
No AI.
Beautiful.
Nothing.
All right. So now you want to take a last aortogram or we are happy?
No, I
with
think
it?
we're good. We're good.
We're good.
We're good.
That do one echo.
No,
let's
no.
make
Echo-
everybody
echo
feel
is
good
there.
now.
We don't
There's
need
no
another
AI, no paravalvular leak. Do a nice your overlap, parallax out, all good stuff.
Okay.
Actually, you
And
see that? Valve is better.
Better
Looks
expanded.
much
for
better
sure.
now after post. With that
No
kind of
aerogram?
Yeah,
chunk.
they're doing
No,
it
we are
now.
doing. We are doing.
We have
Okay,
to set up the
good.
contrast.
Yeah,
We're getting,
For
and
the
then,
old timers.
yeah, old timers.
That was what we was going to say.
Ready?
We go with echo.
Quick, ready?
Yeah.
Wow.
Okay, happy
Nothing.
everybody.
Let
Wow.
us see it. We didn't see the
Good.
aerogram.
Yeah.
There.
Guys,
Okay, now we're talking.
Okay,
Now we're talking.
okay.
Yeah.
Good.
Yeah.
And more important, look, just wait. You can see
Yeah.
You get the nice right coronary
Yeah,
flow
beautiful. Yeah.
and the left main flow. That was the
Beautiful.
question.
Yeah.
So I think it's a beautiful result in terms of this particular anatomy. You cannot go for free or even zero depth. You're going to have run into a problem causing sinus sequestration. So
That's correct.
Or even a pop out with that.
or even
LVOT.
pop out exactly with this kind of calcified anatomy. Great.
So this is the case we are done. Fantastic. Let's talk about some point. But more importantly, we are going to make another history in Mount Sinai. They will do a Saturday tower. We have a one big India live relay this Saturday morning. I know a lot of people are unhappy about it. Some are happy about it. But we need to do it. Continue our name. Okay, let's go to the slides now.
Who is happy? Nobody.
Okay, our slide presentation. So let's talk about few of the points which we have spoken about. The recent publication in the TAVR field. One is the 3-year outcome of the Evolut low risk trial. Remember the SAPIEN partner 3-year data have not come yet, only 2-year. Optimized Pro study, which we have spoken briefly in the past, but now filed in publication. Then sex differences in TAVR outcomes. Redo SAVR after prior TAVR versus SAVR registry. And explant to redo TAVR registry. What a nice name. So no confusion. This is Gilbert Tang, the main author. Explant to redo TAVR.
Oh.
So whatever you are doing is actually in the title of the manuscript. Now first is the 3-year outcome. You remember the low risk patient, STS less than 3, randomized to SAVR versus TAVR with the Evolut, and basically data see significant difference of 2.9%. 10.4 versus 7.4 in favor of TAVR compared to surgery with a p-value of 0.05. All-cause mortality or disabling stroke. So clearly, the TAVR at 3 years superior to surgery in a hard endpoint. We are not talking about the rehospitalization, and the next one is the rehospitalization at the bottom. Of course, clearly makes a difference, but otherwise, clear difference of the death and the stroke combined. Individual don't make a p-value, but difference is 2%. Look at that. 2% in the mortality, 1% in the stroke in favor of TAVR compared to surgery. And of course, rehospitalization is a big issue. These are the individual endpoints. Now, then there had been some issue about the valve thrombosis. Now, there are some data when they have the partner 2 5-year data, there was some valve thrombosis with the SAPIEN valve. But we in the Evolut trials, we did not have any valve thrombosis. And here also, total valve thrombosis 3 years and valve intervention, all less than 1%, both surgery and TAVR. And of course, we knew AFib more with the surgery, permanent pacemaker more with the TAVR. So very clear, superior strategy as shown here with the 3-year outcome. More important, and that is what we need to see. These patients, we are not talking about 3 years, we are talking about 10, 12 years. And that is that residual gradient and the valve orifice. At 3 years, it's a 2.2 with the TAVR and 2.0 with the surgery. Will it translate into a better outcome at 8 or 10 years? We need to see. And of course, the residual gradient correspondingly is lower as shown here. Now, only problem is paravalvular leak. So we are talking about mild paravalvular leak only, which is 20% of the TAVR and of course 2% in the surgery. So yes, surgery do a very tight fit, but we also know mild paravalvular leak may not be associated with a bad outcome, but it's a moderate plus that is a failure of the procedure. But moderate plus does, but mild do not. And we have shown the data here. Better valve orifice, lower residual gradient, lower mortality and stroke, lower rehospitalization in the TAVR compared to surgery in the low risk trial of the 3-year data. So very, very positive as we can see from point of view. The Kansas City quality summary, of course, surgical have a little slow to start, but remain maintained at 3 years. So then second question which we talked about, the optimal technique of the optimized Pro study was for the Evolut valve before the Evolut-FX, and then they actually have the criteria that you do a base patient with the conduction disturbances, non-conduction disturbances, pre-procedure, peri-procedure, post-procedure, in basically that where your valve should be and so forth, and follow up these patients. And these were the key steps. Deployment in the cusp overlap view, marker bend, excess depth in the cusp overlap view, and then of course remove remaining parallax, estimate depth at the left coronary cusp, redeployment in the cusp overlap, and assess final implant depth in the NCC. So now, Gilbert, with the FX, any of these things need to be followed?
Well, I think it's much streamlined now. We still do cusp overlap you saw in this case, and then once you go to 80%, you roll to the LAO immediately.
Yeah.
So you skip a step, and then if it looks good on the left, you release like you usually do. So it's much more streamlined and efficient.
Right. So clearly, this cusp overlap and LAO were very important. What did it show? In both separate groups, the no EV disturbance and EV disturbance, their separate follow-up protocol. We were one of the lead site for the Optimized Pro, and then overall showed that, as you can see, that 1 day median length of stay, 0, moderate or plus regurgitation. So no moderate PVL, less than 1% mortality, and more important, and stroke rate was about 1.5%, and pacemaker rate was less than 10%. Now, they say that 5.8 if you have 4 keys cusp overlap technique which were followed. So I don't think we will get 5.8. We still remain around 8%. So yes, we really follow everything. You are a little lower as shown here. So now the second, these are the now, this is where I was discussing earlier on the Lunderquist wire and without. So every aspect of your pacemaker implantation went lower, particularly when you use a Lunderquist, and more importantly with a 34 millimeter difference of almost 8% pacemaker rate. So this is still, look at this, still high pacemaker rate, but we know that, but overall was less than 10%.
What was the use?
Huh?
30%?
Lunderquist, yeah.
Total use of Lunderquist.
Lunderquist was used
9%.
about in, but
30%?
yeah. A small percentage, but they're left to the operators, not in every case. So they just did the data. For some, lot of people use Lunderquist.
Go back to the slide, SS.
Yeah.
Sorry. Yeah, so 9% in the overall with Lunderquist and 15.1% in the overall without Lunderquist.
Yeah.
So almost 6%.
6% only, yeah. 1, 20, 22, 10.
Right. So clinical impact, we talked about it. The use of tower care pathway and the resulted in favorable clinical outcome with no moderate or severe AR and low pacemaker rate at 30 days while facilitating early discharge and reproducible outcome across various sites and operators. So we are very happy to be part of it. Now, one simple, remember sex differences have been shown that you have higher acute complication in the tower with a female versus male, but female have a better outcome of the tower at a long term. This is the data from the popular TAVI, because we always concerned about the bleeding, and it showed basically that while the overall outcome were not different, but they have a higher bleeding and vascular complication, women compared to male. But if you go down to the aspirin group, we are talking about, of course, anticoagulant have higher bleeding, but aspirin group, as you can see here, aspirin monotherapy or aspirin dual therapy with clopidogrel, significantly higher bleeding, even in aspirin, as you can show. So aspirin definitely is troublesome for women, and higher bleeding rate at this, which we have been consistent. Now then, the redo surgical aortic valve replacement, like this, a patient which will face in 10, 12 years, after prior transcatheter versus surgical valve replacement. So basically was that you have a transcatheter valve, your tower, or you have a SAVR. So question is before, and now what you do. They're basically that they took the patient who have a isolated repeat SAVR, and there they said the tower patient got the surgical valve, and the patient a surgical valve got the another surgical valve. Clearly clear. We are talking about tower going for SAVR or SAVR going for SAVR. Only thing is in this one, they are not looking for SAVR going for tower. So that is the biggest problem in this paper. They did not have the data of the SAVR going for tower. But tower for SAVR, SAVR for SAVR, or if you have a SAVR tower, then went for SAVR was also there. But not there was the SAVR versus tower. So this is just you have to understand the limitation of this paper. And they're showing all these three. Prior SAVR, and these numbers are increasing basically, but more important, we need to know the data. Data is very clear. Once you do a surgery for tower, your mortality was 17% versus you did a surgery for prior surgical valve replacement. So Gilbert, maybe you can comment on this. Why such a difference, almost double? the mortality in a tower. You do a surgery for the tower versus you do a redo surgical valve.
I think that two things. One is the patients are sicker. They can, if a paravalvular leak or degeneration, they just keep waiting. The cardiologists are not referring for intervention. Two is that these patients typically have a lot of comorbidities, and so the operating time is longer. Remember, if you have previous surgical valve, you can just take it out very easily. You cut the sutures, you clean the plane, but the TAVR, especially the latest generation valve with the sealing cup, it really stuck to the annulus and LVOT. So you don't want to be aggressively taking it out, but you can then make a hole in the heart, then you have to do more complex repair. So I think that's what makes the operating mortality higher, and of course, we are still learning. Remember, in the STS database in the United States, the average surgical volume for isolated AVR is only 5 a year per surgeon. So now even less because TAVR is now the default therapy for most patients. So the experience will matter, and I think the surgeons also need to learn how to do this better. But it's tricky, it's tough.
When do you decide to do SAVRs for TAVR versus TAVR in TAVR?
Yeah, so that will come back to the second part of the paper. Very important question. But you're saying something?
He said patients are sicker.
Yeah, you can
so
see
that is
in
what
the, in
he's
the
talking
chart.
about. 37%
Yeah.
in that
So
group.
no, there clearly I said that more comorbidity will go for TAVR. But the question here is different. You already have a TAVR. Now that TAVR should it get a second TAVR or so? That is not part of it. So that's where the whole issue comes down. But anyway, the key is that therefore, what does we learn from this? We learn basically from this and I'll tell you where. So TAVR, isolated SAVR, mortality is 11.3 in propensity score matching, and SAVR, isolated SAVR is mortality 6.7%. And that really puts this very important conclusion. That is, the patient with life expectancy beyond a TAVR valve and unsuitable anatomy for redo TAVR should consider a SAVR as a first approach. And that is where the whole question means, you may do a TAVR 10 years later, but patient has an anomalous coronary, low height and sort of very calcific chunk, whatever reason is. So you should think of the surgery if patient going to live 15, 20 years. So that basically was the message from this paper, because doing the surgery, after surgery is okay, surgical valve deterioration. But only thing is what is not shown here, that how you TAVR do after SAVR, that's the biggest limitation of this paper. Look, good paper, but I think they missed, in my opinion, maybe not the boat, but a small, some point in this particular case. Now, this is a main paper, very big, new research paper, published in JACC, about explant versus redo TAVR after transcatheter valve failure, explant to redo TAVR, international registry. Gilbert, tell us, how did you make this registry, and you are the lead author? How this happened?
So a lot of other registries before even from ours is that they look at patient who had surgery after TAVR, and then they have the one redo TAVR. They never been able to look at all the sites together to decide heart team decision. Are you going to go for surgery or are you going to go redo TAVR? So that's kind of what this registry is looking at. Of all the sites that are combined, what percentage of patients get redo TAVR versus what patients get surgery, because these are the same sites. Now, what we don't know is how many patients got screened out or patient declined, but a lot of patients will refer from other centers like what we have seen. But I think we need to kind of start looking at what is the ratio, what's the proportion, and how they do.
And that exactly was the question of Pedro was earlier. So these are the cases of 396, redo TAVR in 215, TAVR explant in 181. And as you can see here, the increasing number of the TAVR explant are going up. Experience is going up because it looks like the data which have been published 2 years ago in 21, that it was all related to the volume. Centers who do a 2 explant versus 10 explant, mortality goes down by half. But this is a field in evolution. But what it shows basically is that TAVR explant has a higher mortality, and this is limited to 30 days. Yes. So first 30 days, 11.3 versus 3.4, redo TAVR versus TAVR explant, and subsequent difference is not there. So landmark analysis after 30 days is equal outcome. And this is the key slide. Mechanism of TAVR failure. And that's what, Pedro, your question goes down to. Redo TAVR, TAVR explant. Structural valve deterioration, more get redo TAVR. Patient with the paravalvular leak, there was no difference actually in that group. Patient with a patient prosthetic mismatch, higher people go to TAVR explant. TAVR valve thrombosis was not much different. TAVR migration, higher go for the TAVR explant. And then, of course, rest of the outcomes are shown is equal for both balloon expandable and self-expanding, but mortality as shown on the top. In hospital, 30-day, 1 year, significantly difference, almost double, 15 versus 32.4. And second issue comes down to that once you do the TAVR explant, those patients report early in 1.5 year. Why? Because those are the one with the your continuous, maybe more paravalvular leak or more patient prosthetic mismatch, never got better. And so on and so forth, while migrated because of, and so compared to when you do a TAVR, redo TAVR, usually they are after 5 years, like 48 plus month difference, as you can see here. So this basically different type which was done there. So just to put this together, in this first report of explant to redo TAVR, global registry, TAVR explant had a shorter median time to intervention with less structural valve deterioration, more prosthesis patient mismatch, and similar paravalvular leak rates compared with redo TAVR. Because many of the paravalvular leak, we bring them and just do a balloon dilatation. Right, we are doing one case this week. So many of the paravalvular leaks we can take care with a balloon dilatation or plug. Or sometimes people do a plugging also, although that may not be, has not been favored, right? What has been the data on the para PVL closure post-TAVR?
Yeah, post-TAVR is always harder. There's actually interaction with leaflets. Taller frames are very challenging. So the field has moved away from plugging it because the mechanism is totally different than a surgical leak.
Yeah, surgical valve PVL, that does work, otherwise not. Now, TAVR explant had higher mortality at 30 days and 1 year, but similar rates on landmark analysis after 30 days. Also, I just want to say, which I not put the slide here, 2 years ago, we had the TAVR explant mortality about the same, like 25-27%, and dependent on over the time decreased, and also with the volume. 2 versus 10 really decreased, but yes, doing a surgery in the for TAVR explantation is a tough issue. Now, this actually is a very busy slide, but they really put it together with a perspective on the redo aortic intervention. As you can see, if somebody has a less than 65 comes back, they're favoring that you do another surgery. So this is the case, second intervention, because if you do a surgery with the TAVR, now patient lives another 10 years. What are you going to do? Bad issue. Maybe somebody more than 75, I think it's okay. But between 65, 75 or 75, I think you should, patient otherwise very good, can tolerate, should go for surgery as shown here. So let me just complete our presentation today. The 3-year data of the low-risk Evolut TAVR revealed lower mortality and CVA with TAVR compared to surgery. These favorable results, along with better aortic valve area and lower mean gradient after TAVR, has established TAVR as a definitive and effective therapy for all AS patients. Evolut TAVR valve outcome can be improved by optimizing the procedure results. Women have, although now the Evolut-FX may be a little different, women have higher bleeding and vascular complications with similar mortality and MACE outcome versus men in the popular TAVI trial. Recent registry report has revealed redo SAVR after TAVR or SAVR to after TAVR has higher once done after TAVR versus surgery. Means basically, hence patients who are expected to last more than TAVR life duration should preferentially be referred to surgery. Third, a multi-center registry comparing explant TAVR versus redo TAVR revealed redo TAVR as the viable option after TAVR valve degeneration with lower mortality. Hence, TAV in TAV can be favorably recommended for structural valve deterioration causing failed TAVR, as long as biggest issue is the coronary obstruction, right? I mean, that's the biggest issue there. So 3 questions. Following statements are correct for 3-year outcome of Evolut low-risk trial, except which is wrong. TAVR has lower death stroke versus surgery. TAVR has lower death stroke hospitalization versus surgery. TAVR has higher pacemaker rate versus surgery. TAVR has higher valve thrombosis versus surgery. Clearly all 3 are true, and there is no difference in valve thrombosis. Less than 1%. Following statement is false regarding the outcome of the optimized PRO study for Evolut TAVR. Short 1-day median length of stay, no more than moderate PVL, more than 10% pacemaker rate, and less than 1% all-cause death. So clearly, the wrong is C, pacemaker rate was less than 10%. Lastly, following statement is false about the redo SAVR or TAVR after TAVR. Reduced TAVR has lower mortality after surgery versus TAVR. TAVR has higher mortality than TAVR explant. TAVR in TAVR is usually done for structural valve deterioration. Reduced TAVR is usually done for patient prosthetic mismatch. So TAVR in TAVR has higher mortality than TAVR explant. Wrong answer. With that note, we complete here. And if any questions and any comments from on the explant issue, particularly Gilbert is the leader, if you want to make any points on that, yeah.
I have a question for Dr. Tan.
Yes.
In the general surgical literature, an acute mortality for an elective procedure as high as this one will be considered non-surgical candidates. For elective, we're not talking here emergent or urgent. How does the surgical field receive this data?
Well, I think what the surgical field realized that TAVR explant is difficult. The surgeons need to do a better job in actually trying to develop techniques to reduce the mortality. I think the other thing that we don't realize that most of these patients, a good percentage don't just have isolated aortic valve replacement. They actually need mitral valve surgery. Some of them had, ascending aortic replacement or root replacement. So it's not just aortic valve replacement. So the surgical community is actively working. We actually have a working group now among all the expert surgeons. Ishmael here is involved as well to look at how to develop standardized techniques so a low volume surgeon can still have an acceptable risk when operating on these patients if they have to.
And let me ask you, let me add two more of this, that how the transcatheter procedure has been boon to the surgical program. The first studies have shown that when you started TAVR, your surgical mortality went down. You know why? Because all the high risk went to surgery. Recent data just came for the mitral clip. The centers using the TEER, your mitral surgical procedure mortality has gone down. Why? Because all the high risk goes to the TEER. So clearly the transcatheter has decreased the operative mortality in the institution justly by increasing the referral to the transcatheter technique. So it has been a real boon, and that basically turns out to be the heart team approach and the best approach to the patient without the individual bias. And that's where the whole issue comes down to. And we're glad that when Marty Leon started this whole field, having a heart team discussion became the prime. And it's so useful to really like this particular patient. We wanted this patient referred to Dr. Keeney, wanted that appropriate for surgery, but after all the discussion with the surgeon, so felt that TAVR is a better option. Anu, you want to put last line? Your patient?
Now also, I think about the discussion with the patient. Whenever, no matter what we say, we always think the option-wise give a percutaneous versus open surgery, lifelong treatment for the patient and all this. I think patient makes the final decision. When you present everything to them, they see both the interventionist and the surgeon at a separate time, and then they make the final decision. And I think they always opt for the easy way. They're not thinking of a lifelong 10 years, 15 years, 20 years of their life.
All right, Pedro, we are done from our side, and you conclude.
Well, thank you very much for the heart team for this super exciting case. A lot of learning. These sessions are absolutely unbelievable. And this case, as well as all the other cases, are now available this afternoon in ccclifecases.org. We do these very exciting transvalvular therapies the second Tuesday every other month. Their next one will be Tuesday, August 8th at 9 a.m. Thank you so much for joining us.